All right, so here we go. Talking about measles, an ounce of prevention. No disclosures. Here's kind of a more expanded list of some learning objectives. I wanted to first start off by just summarizing the current measles state in our country. So this is looking at a full year in 2025 and then 2026 to date as of, I think it's the third week of March was where the CDC's data was. So the current trajectory, it's looking like we are potentially going to have even more cases of measles in 2026 compared to what we had in 2025. Um, and some other just important data. So currently for the 2026 cases, about 5% or about 78 of the 1575 cases have required hospitalization. There have been no deaths in 2026, but in 2025, there were three deaths related to these cases of measles in the United States. And then looking across our country, this is the routine pediatric vaccination exemption. And something to keep in mind is that although we are not in the darkest of blue, we are in the second darkest of blue in terms of pediatric vaccine exemptions. And this is based on kindergartners, and it's all exemptions, not just medical exemptions. Now, this is a growing issue of vaccine exemptions, which is why if you guys have specific questions pertaining to MMR vaccine exemptions, please include them in the chat. I wanted to take a look at kind of where does Hawaii compare against the US, but also against, I selected South Carolina because that's a state that's seeing a large number of cases. And something that was very humbling and a bit of an eye-opener is that over the last decade, our rate of vaccine exemptions is higher than that of South Carolina. So when you look at how quickly measles is spreading in a state that actually has a lower vaccine exemption rate, I kind of wait for the other shoe to fall in the state of Hawaii for the potential of what could actually happen here in our state. Um, and this is MMR vaccination rates among kindergartners by school year, just going back over for not including this current school year. We don't have that data yet. But again, our vaccination rate against MMR is less than that in South Carolina and then less than the national average. So now let's get into a little bit about measles, the disease. So it starts off as an acute viral respiratory illness that's caused by the rubeola virus, not to be confused with a similar named virus, rubella. It is highly contagious. Transmission is via direct contact with respiratory droplets. It's an airborne virus, and it can stay in the air for up to 2 hours after an infected person has left that room. The R naught is estimated to be between 12 and 18 in an unvaccinated population. And R naught is looking at how many vulnerable people who are in contact with an infectious person can catch or would become infected. It's about a 90% secondary attack rate among close susceptible contacts. Humans are the only known reservoir for measles. Now, the incubation period is fairly long, 10 to 12 days, but it can range between 7 to 14 days. The communicability is generally 4 days prior to and 4 days after the onset of the rash. However, if an immunocompromised person were to contract measles, they are considered contagious for the duration of their illness or their symptoms. But the challenging thing is that because you can be contagious for 4 days prior to the onset of the rash, this contributes to the spread because generally when people suspect that this is a case of measles, it's when the rash appears. Um, and there is a bit of a temporal pattern. So primarily it is seen in winter and springtime. But as we saw in 2025, when you have a very vulnerable, unvaccinated population, it'll just spread. Herd immunity is important to public health when it comes to measles. Oftentimes, when we look at vaccine preventable diseases versus, diseases that are not going to be completely expunged from, the continent, short incubation diseases like influenza, it relies on a lot of circulating antibodies in order to neutralize the pathogen, but these are oftentimes diseases that will mutate quickly, and so we'll never get rid of influenza. We try to decrease the risk of catching it, but more importantly, when we vaccinate, we're trying to decrease the risk of severe outcomes. Versus long incubation diseases like measles and varicella, there's a longer window of time between exposure and then the actual expression of the infection. So if you've got immune memory to a long incubation disease like measles or varicella, there actually is the possibility that we can create herd immunity to the point where we eliminate the disease from, let's say, North America. And we did have measles elimination status at one point in time. We do not have that, I think it was removed because of the number of months of measles infection in the United States. But this is something that is achievable with these long incubation diseases. Now, some clinical features about measles. So it starts off with a prodrome that lasts about 2 to 4 days, and it's fever, usually very high fever, and then the three C's, so cough, coryza, and conjunctivitis. And then oftentimes what we'll develop then is the enanthem or Koplik spots, which are white spots on the buccal mucosa. And generally, that's going to happen about 2 to 4 days after those initial symptoms of fever and the three C's. But the absence of Koplik spots does not exclude the diagnosis. And then the exanthem, which is the rash, the erythematous kind of flat spots that can become confluent, will usually appear about 1 to 2 days after the Koplik spots, or about 3 to 5 days after the prodrome starts. So this is what can oftentimes make this a little bit tricky because there are lots of infectious diseases that can have fever, cough, conjunctivitis, rhinorrhea, but there's also a lot of diseases that can have a viral exanthem. So you need to have an index of suspicion in order to then know to inquire or make or do the testing in order to identify a case of measles. A little bit more about the rash itself. It can also have slightly different appearances in people with more versus less pigment in their skin. But this shows kind of that long exposure period, the incubation period versus the actual infectious period. And then, like I said, rash onset is generally when a clinician is suspicious that this is measles. Obviously, right now, I think people's concern is higher because of measles being in the news, much more measles cases happening on the mainland. But if you don't suspect it, or if somebody isn't coming in to seek care, then this contributes to spread in the community. So usually it's going to go from head to trunk and then to extremities, and then the spots oftentimes become confluent. Usually it's a non-pruritic rash. The rash itself lasts about 5 to 6 days, and then it fades in the order of appearance. So again, it starts head, trunk, extremities, and it'll usually fade in that same order. What's important, though, to understand about measles is the complications of measles. So about 30% of cases are going to have complications, more common in ages 5 and younger or ages 20 and older. 1 to 3 out of every 1,000 children with measles will die from respiratory or neurologic complications. So just reflecting back on the data in the US from 2025, there were a little over 2,000 cases that were confirmed, and there were 3 deaths. Likely that it's still 1 to 3 out of every 1,000 because there were probably cases that didn't go in to seek care. So that tip of the iceberg of confirmed cases and 3 deaths still lines up with the data that we knew from the 60s and 70s. Pneumonia is the #1 cause of death. So about 1 out of every 20 children with measles will get pneumonia. And then encephalitis is seen in about 1 out of every 1,000 children with measles. Some of the longer term complications of measles, though, are something that our country's probably going to see in about 5 to 7 years. So something called subacute sclerosing panencephalitis. It is very rare, but it is considered a fatal complication and a late onset complication of a measles infection. So this is not the same as the encephalitis that can happen in that more acute time frame. This is going to be 7 to 10 years after measles infection. The rate of this happening is about 1 per 50,000 cases of measles. There will be this subacute sclerosing panencephalitis, but that risk goes up to about 18 per 100,000 if the child is less than 5. Oh, this should say at the time of measles infection. Then, if you are 12 months or younger when you get that measles infection, it could be as high as 1 in 600. There's no cure, and vaccination after infection does not prevent SSPE. But if somebody was vaccinated and does get a breakthrough infection of measles, they seem to be protected from this subacute sclerosing panencephalitis. Another long-term or late onset complication of measles is something called immune amnesia. So the virus is what's called a lymphotrophic pathogen, and it likes to infect memory B cells. And so a measles infection in up to 70% of people who get measles will result in basically an erasing of the immune system's memory leading up to the acquisition of that infection. So while you may see or have some people report that getting measles disease is actually better for the immune system, that is actually not the case. Now let's talk a little bit about vaccination and some immunity specific considerations. The vaccine history of measles, so it was first licensed as a single antigen vaccine in 1963. In 1968, there were some improvements to that versions of the measles vaccine. And then in 1971, measles, mumps, rubella vaccine was actually developed. The second dose of MMR in terms of the vaccine series wasn't actually recommended until 1989. And that was because there were outbreaks of measles among school-aged vaccinated children. However, in 1998, Andrew Wakefield published a study in The Lancet that falsely linked MMR vaccination to autism. And it took a long time before really publicly a lot of what he was claiming was found to be flawed and fraudulent. He had undisclosed conflicts of interest. And finally, in 2010, he was found guilty of professional misconduct. The article in The Lancet was fully retracted and he lost his medical license. But by that point in time, the social damage had really infiltrated into MMR vaccination rates declining, not just in the US, but also throughout Europe. So the measles vaccine, it's a live attenuated vaccine, 2-dose series, and it's 97% effective in preventing measles if exposed. Fully vaccinated people are also less likely to spread the disease if exposed. And in the United States, our vaccine schedule is to give the first dose between 12 and 15 months, and then the second dose between 4 and 6 years of age. Now, some of the things with the measles vaccine are that there's a rash that can appear about 7 to 10 days after receipt of the vaccine. It happens about 5% of the time, so it's not insignificant. This rash, however, is not contagious. So that's where getting an immunization history is always going to be valuable in pretty much everyone to know who's unvaccinated, who's maybe incompletely vaccinated, but also who's recently had a vaccine. Another rare but real complication of the measles vaccine is thrombocytopenia. So, measles infection itself can cause thrombocytopenia. So it's not surprising that a vaccine that contains a weakened but live form of the measles virus can also cause it. This is usually something that, if it's going to happen, it appears about 2 months after receipt of the vaccine. This thrombocytopenia is generally going to be self-limited, and it is more common in patients with a previous history of thrombocytopenia. So thrombocytopenia history is not an absolute contraindication to receipt of a measles vaccine, but it is something to consider having that shared clinical decision-making conversation with the family about the potential risks and then how to monitor for it. MMR vaccine can be given to HIV positive patients who do show evidence, who do not, I'm sorry, do not show evidence of severe immunocompromise. And things to consider in the healthcare space. So, presumptive evidence of immunity to measles. You have to have one of the following conditions met. So, written documentation of vaccination. So, 2 valid documented doses of a measles containing vaccine, with the first dose given on or after the first birthday and spaced at least 4 weeks apart. Or laboratory evidence of immunity through measles immunoglobulin type G or IgG, or laboratory confirmed evidence of measles. So a verbal report or a clinical suspicion, even if made by, a reputable clinician, is not acceptable. It has to be laboratory confirmed diagnosis of measles, or birth before 1957. Measles was so prevalent that people who were born before 1957 are presumed to have had exposure to measles infection itself and presumed to have immunity. Now, a little bit more about measles serology. If somebody has an unclear history, so lab evidence, again, is based on the IgG detection. So don't order IgM. That's for more acute infection. But anybody who has a negative or equivocal measles IgG test should be offered MMR vaccination, assuming they don't have a contraindication like pregnancy or severe immunocompromise. Now, if they were born before 1957, you would just administer 1 dose. If they were born in 1957 or later and they have negative or equivocal IgG testing, then you would give 2 doses spaced 28 days at least apart. If they have vaccine records showing they had previous MMR doses, and let's say they're getting measles titers done for work or for school, then you don't need to, and then it comes back negative or equivocal, you don't need to repeat the 2 dose series. They would just be 1 dose after. And there's no indication to then recheck the titers after that immunization. When this is done, oftentimes it tends to be done incorrectly. So if someone has a desire or insists that they have to show positive titers after receipt of the vaccine again, the window of time where you would check that serology is 4 to 6 weeks after receipt of the shot. And essentially that's to catch when that peak of IgG is going to be in their system. If you check 4 to 6 months after and it's still equivocal or negative, the problem is you probably missed the peak window to prove that they're going to have circulating antibody. And the negative or equivocal test does not mean that they are a non-responder to the vaccine. And oftentimes what you may find is then people get in a clinical situation where they're chasing MMR dose and then titer, MMR dose and then titer. So if you specifically are in that circumstance, because you have to get lots of titers done for your job, or you have a patient in that situation, the key thing is if you're going to revaccinate and you want to prove that they had a humoral immune response, then you want to check 4 to 6 weeks after administering that dose. IgM is only indicated for suspected measles cases. However, an important caveat is that it's usually not detectable until 3 days after the onset of symptoms. So there is a risk if you only did IgM testing of having a false negative if you have a suspected measles case. I do have a slide that goes over what to do if you come across a suspected measles case, however. Some special considerations for vaccination. So between 1963, when the first vaccine was licensed, and 1967, there was a lot going on in the measles vaccine development space. So there will be some adults who were born between 1963 and 1967 who were vaccinated with a killed or inactive measles vaccine, and that vaccine is not effective long term. My guess is the average person born between 1963 and 1967, unless they are in the space of infectious disease, virology, or immunology, they probably don't know what type of measles vaccine they received. And so they should either receive MMR vaccination or get their titers checked, especially if they're going to be doing any sort of travel. If they work in the healthcare space, they probably have had titers drawn to confirm their immunity. But anybody who's going to be traveling, that's definitely something to consider is their birth year, and whether or not the vaccine that they received might not have been as effective. Receipt of any antibody-containing blood products, such as immunoglobulin like IVIG or IMIG, but also whole blood or packed RBCs. The antibodies in that product, in the blood product, can interfere with the measles attenuated virus replicating in the vaccine. So depending on what product they received, you may have to wait between 3 to 11 months before administration of MMR vaccine. And the type of product, there's a lot of resources out there that can tell you whether it's a 3 month wait versus an 11 month wait, depending on the type of product that they receive. But just keep in mind, even packed red cells can have some antibody in them that might make the vaccine itself unreliable or inactive. And so you'd want to wait before administration of vaccine. The early administration of vaccine to between 6 and 11 months of age, it's not counted due to the risk of vaccine inactivation from maternal antibodies. Also, those younger age groups, like between about 6 and 9 months, their immune system itself is a bit immature. And so it's not just the passive maternal antibodies, but the actual immaturity of the immune system that can interfere with their body's ability to mount an accurate or adequate response to that first dose. So you just don't count it. So this is just a summary chart of all those kind of different situations and caveats, and then what to do. So there's the standard recommendation, and then there's recommendations in an outbreak situation. Healthcare personnel, we have our own line because if you work in healthcare, the chances of you encountering infectious diseases goes up a little bit, but also the chances of you working with patients who maybe have immune compromising circumstances or maybe pregnant also goes up quite a bit. And so we are our own niche when it comes to both the standard recommendation, but also what to do if there is an outbreak. Something that I've seen circulating in social media spaces, so I wanted to just talk about it, had to do with measles vaccine efficacy and waning immunity, especially if the vaccine is given early in an infant. So there was a 2013 study in the Journal of Infectious Disease, and it found that the age of first dose of measles vaccine is actually the most influential driver in determining long-term vaccine efficacy. So this was a study that looked at the administration of the vaccine given as early as 6 months of age. And they looked at the humoral immune response. So that's going to be your B cell response and antibodies measured at 5 to 10 years of age. And they found that if that first dose was given at 6 months, the humoral response was lower than those who received their first dose at 12 months of age. What was really interesting about this study was they also looked at whether there was presence or detectable presence of maternal antibody in the baby prior to receipt of that early dose, down to 6 months. And because for the most part, we usually say that, that circulating maternal antibody is a factor in inactivating the vaccine. But one of the things was that babies who did not have any detectable passive maternal antibody still had some earlier waning of their humoral immune response. So that led to the conclusion that it's not just the passive maternal antibody, but the actual age and immaturity of the immune system that contributes to early waning of the humoral immune response. Now, an important take home, though, is that cell mediated or T cell responses basically were the same and were maintained regardless of the age of measles vaccine or presence of maternal antibody. So your T cell or cell mediated immune memory, that is what is the most critical in protecting your most vital organs. So your humoral immune response and the circulation of antibodies, while that is still important and can protect you from actually catching the disease, especially if you have lots of IgA in your nasal mucosa. What's going to keep your brain, heart, liver, and lungs safe or safest is really your T cell response. So the administration of an early dose in infants less than 12 months, that does not appear to impact the T cell memory. A cohort tested at 7 to 10 years of age did show that they had lower levels of circulating antibody, regardless of that maternal antibody present. But between 6 and 9 months, it appears to have the greatest impact. And the impact seemed to lessen if the infant was 9 months old, even if there was still maternal antibody present. So if an early dose of MMR were given and the child was 9 months and just under 12 months, the impact seemed to be less or insignificant. So then there was in
Can I
2019.
interrupt with a question from the chat real
Sure.
quick? Just
Sure.
going back to the previous study, Melissa asked if this study accounted for getting the two doses after age 12 months, or if it was looking at a two-dose series with an earlier start. And in particular, because a lot of people have been asking for an earlier dose in light of the outbreaks. Thanks.
Yes, so that's a great question. And I'm sorry I didn't include. So this study looked at getting either two doses if you got it at 12 months or older, or a total of three doses if that first dose was given before 12 months of age. So that's a great question. So they would have been in full compliance with the recommended number of doses on or after the first birthday. Excellent question. In 2019, there was a meta-analysis that was published in the Lancet that also kind of basically it supported what was found in that 2013 study. So there was no evidence of reduced cellular immunity in children who received that early dose of measles vaccine. However, the geometric mean titers were lower in children who received measles vaccine, especially before 9 months of age, before those who were vaccinated 9 months of age and older in all kind of four studies that had really longer term and larger study data. So one of the conclusions that those authors made was that measles vaccine administered to infants younger than 9 months might negatively influence measles specific antibody titers and the actual duration of the antibody titers. But it doesn't appear to interfere with their T cell immune memory. It doesn't appear to be reduced or negatively impacted. So why this is important is because you are probably getting lots of parents who want to get an early dose, and their child is not yet 12 months of age. It is important to just kind of provide some counseling. Now, in the context of what can happen if that same child were to contract measles, especially if they're under a year, my recommendation would still be to get that early dose if you're going to be traveling, because the long-term consequences of a measles infection in a child under a year are much greater than a child who has the risk of potentially having early waning of their circulating antibodies. And they may get measles at a later age, but their measles is going to be kind of what we would consider that breakthrough infection. So much less severe, and it doesn't carry all of the risks because their T cell immune memory is still intact. So I don't want you to stop what you're doing, especially when you have parents who are going to be traveling and they have a very reasonable reason to be concerned, but just kind of add this little bit of counseling moving forward. I think we're going to find more and more data that shows that some of that, kind of, 3 to 5% of patients who are fully vaccinated who still get measles. One, what was the age that they received their vaccine, but also two, what was the severity of their measles case? And from what we know right now is that it's still a less severe case of measles compared to completely unvaccinated. So some things about measles, mumps, rubella vaccine itself and actual medical contraindications. So good news, when I look at the vaccine exemption data in the state, there hasn't been an increase in medical exemptions for MMR vaccine. The increase in exemptions for MMR vaccine within the state of Hawaii is not coming from healthcare providers. It's the religious or spiritual exemption. So I want to say we actually are pretty much compatible with the rest of the country when it comes to a relatively low rate of medical exemptions. But I just want to reinforce some actual, considerations for medical contraindications, severe immunocompromising conditions. When it comes to HIV, if their total CD4 count is less than 15%, or absolute CD4 count is less than 200, they should not receive the MMR vaccine. If a patient has a history suggestive of an immunodeficiency, then the safest thing is to refer them to an immunologist just to make sure that they are immunocompetent before administering it. Now, history of a severe allergic reaction, specifically anaphylaxis to MMR or an MMR vaccine component, such as gelatin, that would be a reason for a medical contraindication. However, the virus is grown in egg protein, but egg allergy or penicillin allergy, neither one of those are contraindications to vaccination. Pregnancy is considered a vaccine contraindication, but that is true for all live vaccinations. Every once in a while, I will still come across a young adult who has not received the MMR vaccine, and it's tied to their egg allergy, not because of any other reason. So egg allergy is not a reason to exempt from MMR vaccination. A little bit more about measles and pregnancy. So measles infection during pregnancy carries risk not only to the mother, but also to the developing fetus. So it increases the risk of pneumonia in a pregnant patient. It also increases the chance of miscarriage, stillbirth, low birth weight, and then preterm delivery. MMR vaccine itself, again, it's a live attenuated vaccine, should not be administered during pregnancy. But if someone becomes pregnant soon after or discovers they are pregnant after the MMR vaccine is given, that's not a reason to terminate the pregnancy. If you identify someone who doesn't have evidence of immunity to measles and they're actively pregnant, it would be important that you counsel them to receive MMR vaccine soon postpartum, ideally before they're discharged from the hospital, if possible. Every once in a while, I get like a panicked call from an ER doc because MMR vaccine was given to somebody, and then a few days later they miss a period and discover that they're pregnant, and they go to the emergency room and they're like, what do I do? And then the ER is like, I don't know. And then they call, and really it is just some additional reassurance, and then just to inform their obstetrician that they inadvertently received a live vaccine during pregnancy. So OB would just do their usual routine monitoring. Now, one of the other questions that I've had happen is, so if a pregnant patient doesn't have any vaccination record, but they have positive rubella titers, can we assume they're immune to measles? And the answer to this is no. And here's the reason why. So MMR vaccine, it's measles and mumps and rubella. and it's a 2-dose series. But in order to provide adequate protection, only 1 dose of the vaccine will provide adequate rubella protection. But in order to get adequate measles and mumps protection, you actually need 2 doses of the vaccine. There was a study, I forget the year, but they looked at 900 samples of, it was Kennedy et al., 900 samples of women receiving prenatal care, and they looked at rubella versus measles immunity, and they found that 98% of the patients had evidence of IgG2 rubella, but only 88% had evidence of IgG2 measles. So if you want to know if someone has immune memory and they don't have a vaccine record, but they had a positive rubella, that just means they had a positive rubella, not a positive IgG to measles. So what to do if you suspect a case of measles? This is the case definition of measles. So it's an acute illness characterized by all the following. So that generalized maculopapular rash lasting 3 days and temperature greater than 101 and the classic cough, coryza, and conjunctivitis. So the Koplik spots are not part of the case definition because, as I said earlier in the talk, not every patient will have Koplik spots. Here's the laboratory criteria for diagnosis. So I want to emphasize this, clinicians should obtain both serology and PCR in a suspected case. So in this instance, you're going to get IgM antibody, but again, the detection of it might take up to 3 days after rash appearance, which is why the PCR is also really important. So you have a concern about false negatives. But then also, if you only did IgM testing, you have a risk of false positives. So I looked up to see which specific viral infections can cross-react on that assay. So the big ones are parvo, rubella, and then roseola can all cross-react on a measles assay and give a false positive on IgM. So while IgM is not perfect, it's helpful when everything fits and the clinical context is right. But also if you get it too early, you might miss cases. So you want to do a nasopharyngeal or oropharyngeal swabs. You can also do urine testing. But your PCR is going to have higher sensitivity and specificity than just getting the serology titers. There are other testing options like genotyping, the IgG seroconversion test. There's a measles avidity test, but at the level of primary care, urgent care, ER, really you should just focus on IgM titers and real-time PCR. But also, please contact the Department of Health and they will help make sure that you get the right testing materials and the tests are done the right way. Once you have a case of measles or a highly suspected cases of measles, and again, in consultation with the Department of Health, there's different options for post-exposure prophylaxis, and this varies based on several factors. Factor number 1, the age of the patient. Factor number 2, the immunization status of the patient. Factor number 3, the time in hours or days since exposure to the measles patient. And then on the next slide, it goes into the last factor, which is the health condition of the patient, whether or not they're pregnant or immunocompromised. So as you can see, it can get very tricky very quickly in terms of who needs to quarantine, how long they should quarantine, who doesn't require any post-exposure prophylaxis or quarantine, who should get either IMIG or potentially IVIG versus who doesn't need that. And then it gets even more complicated when you have pregnant patients and also immunocompromised patients. So I include this here not so that people feel comfortable now managing on your own, which you should not do if you have measles cases or suspected measles, but just to add in the intricacies and also emphasize the importance of contacting the Department of Health quickly in order to make sure that the majority of the patients who are eligible or in need of post-exposure prophylaxis are getting it within that 72-hour window. So one of the questions I throw out to the group is to take a look at your clinical work setting, especially if you don't work within a hospital system, but you work in a private practice, what's the plan in your clinic? Does your clinic have, kind of a plan of action if a suspected measles case presents and is in your waiting room, versus someone calls, and how do you triage that? Have you reviewed the plan with all of the clinic staff? So from the medical assistant who's greeting the patients to the person who is scheduling the patients. And another thing to consider is, are all of your clinic staff immune against measles? Again, this is assuming that you're not working for a hospital system where it was part of your routine in processing to get, different titers done. Do you know if your staff are all immune against measles? And then if some are not, how do you kind of shift around who's working with which patients who maybe come in with a rash and a fever? Do they stay away from all of those? Have you kind of thought about what steps to take? So hopefully the next few slides will give you some helpful information just to consider. So precautions in a clinical setting, inform your staff to utilize virtual visits as much as possible. Patients with suspected measles should not be in a patient waiting room. And that's because the virus can remain for up to 2 hours in that space. You want to adhere to airborne precautions when caring for patients with either known or suspected measles. Immediately placing that patient, if they come in person, into an airborne infection isolation room, and then only staff with documented measles immunity should enter the room. They should also be following airborne precautions. Notify the Department of Health, and then limit the transport of that patient. So for example, if you can do the necessary blood work and testing in that room, that is better than having the patient go to a lab facility and then potentially exposing a whole bunch of other patients. After the patient leaves the room, that room should remain vacant for the appropriate amount of time, which is about 2 hours, to allow for about 99% of the airborne contaminant to be removed. Also, patients with confirmed cases of measles should remain in an airborne precaution for 4 days. This is assuming that the patient has to be admitted to the hospital. The day of rash appearance is considered day 0. So the airborne precautions should be up through day 4. Again, if someone is immunocompromised, they can shed the virus longer, so their airborne precautions should go longer. Unvaccinated, non-immune people who are exposed to measles need to quarantine for 21 days unless they get vaccinated within 72 hours after the first exposure to a confirmed case. Now, if you are working in healthcare, which you all are, even if vaccinated within that 72-hour window of time, because that is not a perfect post-exposure prophylaxis, your workspace may still have you isolate or kind of quarantine from work for a longer period of time. That again can be done or decided in coordination with the Department of Health. Standard cleaning and disinfection procedures, like using, cleansers and waters and pre-cleaning surfaces and disinfecting services, those are all adequate for measles virus environmental control. So you don't have to have a special cleaner. What you probably have already is adequate to do that. Again, this is kind of a summary slide on the different actual treatment options. So it includes either IMIG, so intramuscular immunoglobulin, or in the case of pregnant patients or adults or larger children, it would still be 400 milligrams per kilogram, but IV administration, so IVIG as post-exposure prophylaxis. If nothing else, if this is the only slide that you decide to look at a later date, you're still going to be good, because this is based on island, who to call even after hours if you have a suspected case. So measles is considered an urgent notifiable condition. So you do not wait for laboratory confirmation. As soon as you suspect, you contact the Department of Health, and then they will kind of help you walk through what to do. If the patient's physically in your clinic, don't let them leave the space or the isolation room that they're in until you've had that conversation with the Department of Health. So with that, I want to stop sharing my slides, and then we'll open it up to the submitted questions. Or do you want to do the after questions first?
There were a couple questions in the chat. I answered some of them, but I didn't know the answer to all of them. So maybe we could do that and then do the quiz. Would that be all right?
That sounds great.
Right. Thank you for a great talk. So the first question was, what is the vaccination rate in the Marshall Islands? I found a report from the CDC for FSM in general. I don't know if you have any better information on that.
I don't have any more current
Okay.
information, but this looks pretty consistent to kind of what I've read about some of the other areas in the Pacific.
Great. Another question I had no idea the answer to is whether the mechanism of SSPE is known.
No, no, and I was looking through that because again, it's a very specific, devastating neurologic outcome, which is progressive and considered fatal in all cases. When I looked through, I didn't find any identified mechanisms. But when you think in the big picture about what we know about viruses, so think about things like shingles. Once you get that virus, it's hanging out in your body somewhere, and when it hangs out in the nervous system, a decade later, it's may come, back. So why and why it provides such a devastating neurologic outcome is not specifically known, but fascinating. If anybody were to be interested in like neuroimmunology and virology, I think that if we could identify the why, potentially could some sort of post-infectious preventative treatment be used? I think that would be great. But vaccination after the fact doesn't prevent those rare cases of SSPE. I think that's what's most frightening.
Thank you. I think we got the other questions covered, and there's a couple thank yous in the chart in the chat. So, folks, while you're digesting, oh, hold on. Are you aware if the Department of Health has considered a campaign that could help with herd immunity education? I could be wrong, but I feel like so many parents don't understand the concept. Do you want to answer that? And then we'll make that our last one before the quiz.
Yeah. So the Department of Health is actually like they have had like ongoing education regarding measles, as well as kind of improving and increasing a campaign against like varicella. But measles for over a year has been a key disease that we try to go out and do education on. Um, so one of the things about how much or how little kind of you push is you want to make sure people have adequate access to it and or reinforce the use of your pediatrician if you have questions. But what we've just found is that MMR is one of the vaccines, in addition to like COVID and flu, that the vaccine, if people are going to refuse vaccines, it is one of the top ones that families refuse. But we do provide, again, education campaigns. They do work on that. I don't know with the most recent measles case in the state that happened because I think I was off island on spring break, so I disconnected. What I was seeing in the kind of local news comment section on social media is again people trying to blame the vaccine because it was a case of measles in a vaccinated individual. So they were trying to say, see, the vaccine doesn't work. So one of the important things is to reframe and re-educate that situation because of some factors unique to that patient.
All right, folks, we'll give you another couple of minutes, maybe a minute and a half or so to finish up the post-test questions. I see about almost a third of folks have participated. So go ahead and get your answers in. And don't worry, it's anonymous. So if you're not sure, feel free to answer anyway. We can't see who, wrote what. So, and don't be shy because wrong answers are just a great opportunity for us to kind of reinforce important learning points. It's not in any way a judgment.
And while you guys are filling that out, so it looks like Linda Kim had asked, what if your clinic doesn't have an airborne infection isolation room? And that's why I kind of included a slide. Like have you considered like, or have you looked at your space, your workspace, and your coworkers? And if your clinic doesn't have an airborne infection isolation room, then it's important to consider what to do with those patients. Are these patients that you have remain in a vehicle and then you go out to the car and you evaluate them? So these are that's a great question, and I figured more so in that private practice or small practice setting, you may not be as amply equipped as, let's say, an urgent care or a bigger kind of clinical setting. So I think now is the right time to consider what would you do, um, not just in the case of measles, but also if, chicken pox comes into the clinic waiting area or pertussis, really all of the vaccine preventable infections. Oh, you work in juvenile detention. Oh my goodness. So, if you haven't already, I would talk to whoever kind of that your medical director is. If that medical director is you, then I'd probably reach out to the Department of Health to kind of meet with someone to strategize and talk about what you do. Because now you're talking about an enclosed space with limited options on where someone could be seen. But thanks for adding that context.
All right, folks, I think we have well over half of you have submitted an answer. So why don't we go ahead and review them? Most people got the questions right, but if you wanted to just really quick, Dr. Mbuthia, go over the the answers just to make sure that everybody is in good understanding.
Yeah, yeah. So the first question, which of the following is recognized as an absolute contraindication to the administration of live attenuated MMR vaccine? Pregnancy. So that is the clinical condition for any live vaccine. The one I tried to trick you with is administration of an inactive vaccine less than 4 weeks. So the spacing of 4 weeks between vaccines only pertains to live parenteral vaccines, not to inactive or an inactive with a live. Number two, patient suspected measles evaluated in your clinic, and you want to prevent nosocomial transmission. And so, what are you going to do? Airborne precautions, including airborne isolation room. That is the best answer from the options that are there. Healthcare worker born in 1998 who had no written documentation of measles vaccine, and they are not pregnant, otherwise healthy, and equivocal IgG testing. So in that situation, you have no written documentation, no contraindication of receipt of a live vaccine. So you would administer 2 doses of the MMR vaccine separated by at least 28 days. A healthy unvaccinated 19-year-old driving in a rideshare vehicle, confirmed case of measles, and the key thing is it's less than 72 hours. It's a healthy person with no contraindications to getting a live attenuated vaccine. So his post-exposure prophylaxis recommendation would be administration of MMR vaccine within 72 hours of that exposure.
Thank you. That was super clear. Appreciate it. There's another question about where is the best place to quarantine for a patient who is either ill or exposed, but not needing hospitalization. Are there any practices that you can recommend for home? Obviously, they will go home, but unvaccinated family members, or what recommendations would you have for such a family?
So important things are going to be that when possible, if it's an older child, so to give them their own bathroom, and to kind of have them have their own dedicated space, so that way family members aren't all sharing a kitchen or bathroom. Easier said than done, but also making sure that the rest of the family members, if they have not been vaccinated and do not wish to be vaccinated, essentially having everybody kind of isolate. Masks. So N95 masks are going to be important to try to decrease viral spread. But then ideally kind of making sure that they aren't leaving kind of the confines of the home to potentially bring it to like the grocery store or to church or other community spaces. But I think as we all learned during COVID and trying to isolate and keep people isolated, it's easier said than done when you have a 4 bedroom house that has 1.5 bathrooms and 5 or 6 family members. Trying to give one infected person all the space that they need is hard. For younger kids, I think it's even more important to recommend vaccination for the caregiving parent because you're not going to have the toddler taking care of themselves for that window of time, but also you want to mitigate the risk of that caregiver adult from getting measles as well. If they are unvaccinated or undervaccinated, really emphasize we are trying to decrease the spread outside of your home, but also if you, the caregiving adult, now become severely sick, well, now that takes you out of the caregiving role, and we need to find someone to provide care, and it just kind of multiplies within your household. Yeah. But great questions. I hope I've given just enough fear that everyone kind of takes a pause and reevaluates like their plans within their workspace, but not so much fear that you cry.
Okay. It looks like Dr. Nishimoto posted the Instagram link for the Hawaii chapter of the AAP. They've had some really, really good content out recently about, trust in your pediatrician and ways to stay safe and so on. So thanks for that really hard work to the AAP folks as well. All right, we have like one more minute if anybody has any last burning questions. This was a great talk, covered in fact, I was like planning some questions to ask you, and then before you finished, you answered them all. So that was great. Thank you to everybody out there, because this is rough for all of us. We worry about vaccination rates falling. We worry about our kids getting sick, in our practices, in our hospitals, whatever. It's a rough time and it can be really exhausting, honestly, to be in pediatrics. So having good information is just incredibly helpful to us. So folks, thank you for joining us. Dr. Mbuthia, thank you for educating us. And this will be posted online shortly, along with the slides. So if you have any friends that missed it, they can certainly come and listen in later.